Senator, welcome back to Senate Spotlight.
Thank you. Glad to be with you.
Absolutely. So you have a very interesting proposal. You have Senate File 3612, which is what you're calling patient-centered care legislation. And that would remove private insurers, or HMOs, from Minnesota healthcare programs. So that is a lot. Let's start at the beginning. What is our current system?
Sure. The current system, Medicaid, which is the main public program around the country for low-income people, Minnesota has almost 1 million people in that, and we have Minnesota Care for just incomes just above that. So we got a fourth of the people in the state in those public programs. And those public programs were truly, they're 100% paid for by taxpayers. And these are for very low-income people. And over the years, 30, 40 years ago, people would say, hey, we could save money if we privatize this and we allow what they called HMOs to come in there and they will deliver the care. Instead of paying the doctors and clinics and hospitals and so on, we'll instead have these HMOs come in and we'll pay them and then they'll pay the doctors and everyone, and they were going to manage care, and they call them managed care organizations. And it was going to save money. There's a report out recently from Congressional Budget Office on how Medicare Advantage, the privatized version of the Medicare program, how it's costing much more than 20% more than the traditional Medicare is to the taxpayers. It's a little bit cheaper for some people, but the care problems, whatever. So we have a system since for 30 plus years, we've had a demonstration project. We never evaluated it, never considered whether it was cheaper or more expensive. And we've been doing all these things. In theory, we're managing the patient's care. I'd argue that much of the managing of care of the managed care organizations is managing their claims payments, even if that's contrary to managing care. And we had testimony about how we would do this. The system right now is very expensive, very uncoordinated kind of thing. And I think we could save money by removing the health plans and paying providers directly, and also putting more effort into the care coordination and the case management and the wraparound services that patients need to help navigate the healthcare system.
Okay, so care over claims is what you're saying. Let's talk to your bill. You kind of mentioned a little bit of what it would do. You want to remove those private insurers. Can you explain anything more there?
Sure. Right now, if you are a Medicaid patient, you are given a choice of which insurer you want to use. If you don't pick one, they assign one to you. Then you go through them, and most people are in some health plan or another, and so they get the care, whether through their employer or whatever. And they can go to certain doctors, certain clinics, certain others, and they have all these standards and so on. Well, this has caused lots of problems, especially in the Medicaid program, because like one of the providers a few years ago got outbid by another one. So in a whole lot of counties, people had to switch. There was 100,000 plus people had to switch. Medica, the one that took over it at that point, then a year later, they decided they didn't want to stay in that market. So they dropped out. 300,000 people have to switch all their doctors, all their prescriptions, all their everything else. A couple of years later, Medica decided they wanted back in, so another shift. Now UCare, which was one of them, they're out completely. Always this churning and everything else. If you talk to nurses, you talk to people who are working with patients, and they will tell you how much time they spend struggling because, oh, that drug isn't covered under your plan anymore. And switching all that, and the doctor and patient, it's terrible for the patients. It's very painful for the doctors and nurses to see the troubles they have. So we're trying to replace it with a single statewide. People are going to go, it's patient-centered. They can focus on them, and we're going to provide benefits to the primary care clinic to help them coordinate care better.
Yeah, you've talked about how our current system creates barriers to care for patients. If your bill were to go through, how would that impact our healthcare providers?
Sure. Healthcare providers, I say, will be much better off. And frankly, Connecticut, which is the one state that's effectively moved away from this, and you know, Connecticut's the insurance capital of the country, Hartford insurance stuff. But they moved away from this about 12 years ago because there was no transparency in the system. You couldn't figure out where the money is going, all those sorts of things. They moved away from it, and they increased benefits for primary care providers. So they had an increase in primary care providers, doctors and nurses who are willing to cover these patients. And they found out that specialists who they didn't increase the coverage for, the pay for, they increased in numbers too. And I think it's partly because if you talk to doctors or any providers, they spend so much of their time fighting to get past prior authorization problems and so on. And so it really helps not only the patients, which Connecticut, there was an attempt by somebody to roll it back and go back the old way again. And the patients groups and their advocates who were strongly opposed, the providers were strongly opposed, and they didn't go back. They kept it because they're saving money, lots of money.
You mentioned how this will help patients and providers. Do these benefits extend beyond those groups? You've kind of mentioned, economic efficiency. So
Right.
would this have an impact on taxpayers or the state's budget?
Well, first thing to think about is the most expensive item in the state budget. Probably more of the state of taxpayer money goes to education than to health care, but not by much. And in the state budget, when you count state and federal contributions to Medicaid, it's like close to $20 billion a year. Less than half of that's the state portion, but close to $20 billion a year. Our entire state budget is about $35 billion. I mean, 10 of that's federal. But it's a huge chunk of our state budget. And Connecticut, over the last 10 years, has said they've been saved about 14%. And if you save 14% of $10 billion, we're talking billions of dollars in savings per year. So it's huge benefit to the taxpayers. And I'd argue, I'm not doing this because it saves money. I'm doing this because it improves care and keeps our healthcare system from crumbling, which is what I'm afraid it's doing right now.
I have to ask, you're mentioning Connecticut a lot. Connecticut, Minnesota, would it be apples to apples or would it be a little different?
No, we're not copying exactly what they did and so on, and they're a much smaller state than us. But, if they save that much money, it's a huge benefit to us. And when you can get better care, and you have patients who are so angry at insurance companies because they feel they're denying care. You go in, you and your doctor make a decision, I think you should get this kind of care, and you say, I think, yeah, that's right. You discuss what care you get. Oh, but we got to get approval from somebody else. I don't want government, I don't want employers, and I don't want insurers to be interfering in that patient-doctor relationship. And I think that's why we're focused on patient-centered care. We want them to make the decisions.
If we remove those middlemen who are making the decisions right now, who takes over that responsibility?
Sure. Well, first of all, we would have the state would contract basically with a claims payer, and purely administrative. We're calling them administrative services organization. Frankly, some of the health plans might decide to because they've handled claims for smaller portions of the state. But just say for this 1.3 million Minnesotans, 1/4 of our population, you will handle all the claims payments and everything else. You will be the ones who pay the providers, you get the bills and everything like that. And so they would handle the administrative stuff. But the thing that we're doing different than simply kicking the insurance companies out, we are saying some of the money that we're paying that's supposed to be going to coordinating care, we're going to directly do that. Who are we going to do it with? Two ways. One is we're going to pay the primary care clinics, give them a bump in pay to help coordinate maybe basic things like if you had your flu shot, have you gotten these things taken care of, and helping that basic stuff, but also working with the counties. 33 of Minnesota's rural counties have what we call county-based purchasers. They're wonderful organizations run by collective groups of counties. County board members serve on this. Republicans and Democrats alike have given strong support to the county-based purchasers. We think that's a great model, and they're providing all these things to help people get to the right providers. If somebody struggles with mental health challenges, help address that. And so we would be requiring the Department of Human Services to contract with those county-based purchasers to continue doing those services. But we want that to happen in other counties too. So what's being done now by insurance companies, in theory, what we're paying insurance companies to do, we would now be paying directly for, largely to the counties, other nonprofits who can help with mental health or whatever issue, dental, whatever.
Yeah, I know that was something that some of the critics have brought up. The Minnesota Council of Health Plans talked about how MCOs, or managed care organizations, can address social drivers of health issues, and it sounds like you would be using DHS in the counties to deal with some of that.
Well, we basically using the providers. The difference, the doctors, I shouldn't use providers, people don't talk in terms of providers, doctors and nurses and clinics. Instead of saying that some insurance company is going to manage your care. We want your doctors and nurses and clinics to be managing the care. So yes, we want to make sure that that's done. And we had one of the witnesses I had last year speak to the bill, and I think the House is taking up the bill soon as well. And she's a provider at a low-income clinic, and talks about how much time she has to spend trying to help her patients get this, because she's told, no, you can't get this. A lot of what they say is managing care. When I say it's managing their claims, they're interfering with the care. They're saying this patient was getting along very well on this medication, but no, we don't want to cover that one, so you got to switch to this, even if it's not as effective. And to me, the time that these medical professionals spend on this is wasted time. So I'd say, yeah, they've been calling themselves managed care for years, but the testimony we have from medical providers is saying they're interfering with care, not coordinating it.
With DHS having a possible role in this, is there any concern with their management? I know they face some scrutiny for some of their program management in regards to fraud, things like that.
Right. And I'm very concerned about the fraud, because there's happened here, and by the way, a new report saying about how many states are having the same stuff. In Minnesota, we've at least identified a lot of it, and I'm horrified at how much money has gone. I think some of the numbers thrown out are wildly inaccurate and so on, but hundreds of millions of dollars is not okay. And we have to address that, and I'm really pleased and been supportive, and I think we've made some good changes the last couple of years and have to continue to. I support Inspector General statewide. I think we have to do those things. But no, what we're doing here, I mean, when they say, oh, we're turning it over to the state, no, we're turning it over to clinics. Instead of turning it over to insurance companies, we're turning it over to medical providers, and in some of these cases, things the counties are supposed to be doing. Because if you are a county, like these county-based purchasers, the reason they're so successful is if a patient falls through the cracks because they're struggling with chemical use, whatever they're struggling with, and the health plans they don't have the incentive to do it. It's coming out of their pocket. But on the other hand, the counties, if some person falls through the cracks and they become homeless, that's the county problem. The county taxpayers end up paying so much for that. The counties have the incentive to intervene, and that's why these county-based purchasing counties have been doing that. Lots of others, Hennepin, Ramsey, all the other counties do a lot of that anyway. We want to just incorporate that here so it's more seamless for the patients.
Senator, let's talk about support. This idea, you got support from the governor, you've gotten support from the American Cancer Society, but your bill so far only has DFL co-authors. Are you expecting any collaboration from across the aisle?
Oh, I hope so. Let me say a couple of things. One, I've seen over the years we've had a number of Republicans who strongly agree that this is interfering with the care we have. The model I'll give is a state that's done it, Connecticut. It was bipartisan. I mean, I don't know when it passed in 2012, if any Republicans voted for it then, but it's kind of unanimous among the legislators. No, we don't want to go back to what we had. This is much better. It's cheaper and better. So I'd say, yeah, I'm not sure if we're going to have it. I'm not expecting it to become law this year. I'll be real clear about that. We don't have the fiscal note yet. We don't have all the details. But I'm not expecting it to become law this year. I just think we're finally moving in the fact that the governor has said, yeah, we got to do this. And part of that the issues about fraud and so on, when they investigated the fraud recently and so on, they're looking at the fraud in the department's managed part, but not in the health plan's managed part. We just haven't been doing that. And their response is, well, we've got the incentive to do it. And I thought, no, the way the contracts under federal law work is if they have an expense where it's fraud, even if they have a criminal fine, a penalty or something, we have to reimburse them for that in the end. So there's no transparency on there. And we want to just have a system, the simpler the system, the easier it is to catch fraud.
Yeah, you said this law probably wouldn't pass this year. Big ideas take time, especially to do them right. Currently, we have a bunch of private insurers. I can't imagine they love this idea, so they'll have some more time to bring up opposition. Are you working with them, meeting with them, discussing ways to work together or to improve the current system?
Sure. I mean, for the last many years, I've been working to improve the current system, and that means working with them many times and so on. on this issue, they see fundamentally, hey, you're saying we're not going to be playing a role in this, and I'm saying yes. So we were on opposite sides. I'm happy to talk with them. They asked me afterwards what I meant by something in the bill. No, I don't expect to have their support on it. And again, I'm not saying they're bad people. I'm saying that the insurance model we have right now is it's in their incentive to, they're managing the claims. And we don't have for-profit ones in the public programs anymore. We didn't until a few years ago, but even the nonprofits here that we have here, they have their own incentive system, and it hasn't saved us money. It's been a total black box. I've heard Republicans and Democrats say, we don't know how much we're paying them. And I'll give one illustration about this too, and this is a little bit off of the insurance companies, whether they support this or not. But in 2011, the state was overpaying these folks because it's pretty hard to do contracts when you can't see all the data. And they were overpaying them and didn't know they were overpaying them. And UCare, one of the smallest of the HMOs, recognized they were way overpaid that year, and they made a charitable contribution, $30 million, one of the largest charitable contributions in state history at the time. They didn't make it to some private college or University of Minnesota or some charitable nonprofit. They made it to the state of Minnesota's general fund, $30 million. If the system is so, because they were repaying some of the overpayment they had. The state didn't even realize they were overpaying. This has been going on for 3 decades. We've never analyzed that in a good way, never independent audits. And to me, we want to make sure this is done right. But if we've got such a low confidence in our ability to negotiate those contracts, that one of the recipients of that says, yeah, you really overpaid us a lot, so we'll make a charitable contribution back to you. That just shows how far it's been from frugal responsibility, treat the government's money frugally, and I think that's what this bill does.
Can you tell me more about that, the conflict with negotiating those contracts? Why is it so unclear?
Well, it's partly because they see everything's proprietary data. I mean, personal health records. If I'm in Medicaid and you're my provider, if you're my doctor, you cannot share any of my medical stuff with anyone. And the health plans also claim all the financial stuff going on there, how much they pay you, how much the claims are, whatever everything are. They have to share some basic claims data, but they're very non-transparent about it. So we really don't know. And the thing that complicates it is the federal government has a thing they call actuarial soundness is the terminology they use, which if you're thinking actuarial terms, yeah, has to be sound. And what that means to them is we have to cover all of the costs the health plans have. That's why I said earlier, even if they have a fine or a penalty, the taxpayers have to cover it. And so if they come in and say, here's our expenses, well, we can look at some of them and we think you overdid this and we can try and do that. But bottom line, we're mainly trusting. And if there's fraud, they say, oh, we got all this incentive to root it out. Well, I haven't seen any reports of anything. They're not transparent about where they're finding it. And if you think in 30 years hasn't been any fraud in any way against them, I say that's not very likely. And we don't have any idea what it is. But if they pay out in fraud, the next year our cost goes higher because they paid that much more out. So to me, this is really helpful for the fraud thing and more accountability, because I don't blame. It's hard to negotiate these. No state does a good job of it.
All right, Senator, final question. You know, you've said Connecticut is the insurance capital, but we have a lot of people here in Minnesota who work for insurance companies. This idea might make them uncomfortable or feel uneasy. You know, what do you want to say to those guys?
Sure. Well, 2 things. One, this is not my end-all goal. I want to make sure we have a healthcare system that covers everyone for all their medical needs. We are nowhere close to that. Affordable Care Act tried to cover more people. Everything Democrats and Republicans have done to try and reform healthcare have always been to try and cover more people. And then, oh, we can't give them coverage for dental. That's too expensive. We can't do. I want coverage for every part of the human body, including the mind, the mental health stuff. I want to make sure we cover everything. And in that, we would, on my proposal Minnesota Health Plan, which I think is also gaining support, we would be saying we're not going to have insurance in there. We're not going to have health insurance. You're a Minnesotan, you're covered. And you're going to pay premiums based on ability to pay, but you're not going to have co-pays and deductibles. It's going to be a simple system so you can go to the doctor, the dentist, or the chiropractor whenever you need it. The goal of a healthcare system should be to keep people as healthy as they can be and get them the care they need when they need it. And in that case, we wouldn't have insurance companies. And as you mentioned, we have some very large ones, and the largest one nationally in here. And that would be displacement. They would not be, they don't sell, they're not in the public programs now. They wouldn't be in a lot of business here in Minnesota. And that would be layoffs of people. Well, under that system, you have to figure out, if we're bringing down the cost of healthcare by billions and billions of dollars in that case, that can pay doctors more, can pay more for this. And frankly, we have a shortage of so many other things. Those folks, my bill for that would be providing retraining funding and dislocated worker benefits. And you don't even need to retrain all of them. The former head of United Health Group was a doctor. He doesn't need retraining. He could just go practicing. We couldn't match his $105 million a year salary, but we want to make sure we take care of people. I want to treat people who are working for insurance companies and people who are processing claims. I want to make sure they're all treated fairly. But we don't want them interfering with care at a great expense to the public. Same thing, pharmaceutical industry. We need the pharmaceuticals, but we don't need to pay exorbitant prices to get it. We should pay fair prices. And that's what we want, a fair, logical healthcare system. And so, yes, I'm not arguing that the health plans should like this, but in the long run, they and their families would have better healthcare with a system like this.
Senator, thank you so much for the conversation and for your time.
My pleasure.